Okay, there we are. It's 1 o'clock on a Friday afternoon, folks. Welcome. It's an absolute delight to welcome you all here. If you're watching this on catch up on recording, you can interact with us as much as you like, but we won't be able to hear you. Just pointing that out to you. But do please enjoy the experience, because today we've got a real blockbuster of an afternoon workshop for you. We're looking at optimization to improve surgical waitlist management. And we have a galaxy of stars of the genre who are going to talk to you and explain exactly how they go about their particular work. We're going to go in various order, but allow me to introduce all three. First up, we're going to start off by having a look at the national perspective on early screening with the one and only Joanna Simpson. Then we're going to look at digital pathway redesign to enable early screening, and that's an example from Guy's St Thomas's NHS Trust by Dr. Ramai Santharapala. And then we're going to go into identification optimization of the complex surgical patient by the one and only Professor Jagdeep Desi, who is also president of the British Geriatric Society. So welcome all three of you. I know this is going to be an absolutely stellar event. We're all much looking forward to it. Unfortunately, I'm going to have to ask Desi and Ramai just to step down for a moment, because Joe, it is your turn to be in the spotlight. I'm just thrilled on behalf of the Institute of Health and Social Care Management to welcome you to the event, and we look forward to hearing from you. So if you'd like to go ahead and share your screen and so on, take it away, Joe. Thank you.
So I'm a consultant anaesthetist in Colchester, and I've been working with NHS England. So I hope that I can give the perspective on the early screening policy, both from the point of view of a clinician who is on the ground seeing how things are happening on a day-to-day basis in a district general hospital, right through to the sort of national perspective that I see from my NHSE role in terms of delivering policy to improve our surgical pathways. So I hope that's what I can give today in this overview. So I thought I'd start with the perspective of NHS England's perioperative care programme in terms of what we're trying to achieve. And these are pretty big ticket items. So we want to improve patient quality and experience. We want to reduce the size of the elective waiting list, which obviously is on everybody's mind as a target for the NHS, and that's been set by the government to be done by the end of this Parliament, and to accelerate the referral to treatment time, the return to the RTT standard, so 18 weeks. And then we also, at the same time, whilst doing that, want to make sure that we're addressing other agendas that sort of that interact with what we're doing, that are looked at by other areas, so prevention, healthcare inequalities, and environmental sustainability. So I thought I'd show you, this is a sort of little table that I drew out to show you how the early screening fits into all these goals. So if our broad aims are improving efficiency and quality of care by streamlining perioperative pathways, I think early screening fits into all of that. And the things that we measure is, we do measure how much early screening is happening, and optimisation. We need to look at whether patients are fit to go before they get given a TCI date. We also measure postponements and cancellations, theatre utilisation and day case rates, and these all reflect whether whether our perioperative pathways are working well. And early screening is really important to help deliver that. And I hope that through this talk you'll see how and why it's important. So NHS England published some guidance quite a while ago now to ask trusts to introduce early screening for patients on inpatient pathways, and the target was that this should be delivered by March 2024. And as you'll see later, this probably hasn't been completely delivered in every trust, and there are various reasons why, but that was the original objective. And these guidelines have subsequently been updated in this month, in fact, with just a few tweaks, to be honest, which haven't really changed things hugely, but I thought this is a slide which shows what the changes are, and I've put this up really not for you to read it in detail now, but so that you've got the links to some additional guidelines have been embedded into the document So I thought it would be helpful for you to see this so that you can access those bits of guidance that GERFT have produced on things like developing pools of fit patients, the perioperative care coordinator training from the UCLH Healthcare Academy, things like that, which are helpful. So it's not a major update to the early screening guidance, but it's a few small tweaks. And what did this guidance tell us that we have to do? So it told us that when patients get put on the waiting list, we should be screening as early as possible for risk factors which will affect their perioperative pathway. That we need to identify these and then optimize them as much as possible. And then we should get in contact with patients every 3 months to check that there haven't been any changes to their health, that we should be giving patients a TCI date only once they've been passed fit for surgery, and that patients should be involved in shared decision making. And I think Jagdeep will speak in more detail about that later. So I stole this infographic from CPOC, and I think the important thing about early screening is that what we're trying to do is shift the focus to the beginning of the perioperative pathway to improve the way that we assess patients right from the start and make sure that their assessment is done in a sort of individualized fashion so that we give the right resource to the right patients. It should also smooth their passage through the pathway so that we get them through to their surgery date as optimized as possible and as efficiently as possible. So the idea is that we shift the emphasis to looking at patients right from the beginning of the pathway rather than dealing with things sort of at the last minute before they have their operation, or even picking up the pieces afterwards, which obviously is not a good way to approach things. So this is another slide that I made years ago, and it's a bit rough and ready because my PowerPoint skills are not amazing, but I think it's a slide that I keep reproducing because I think it shows why we need to screen and triage patients early. And the reason is that that patients obviously have very different needs when they come through for operations, right from those patients at the top there, the sort of athletes having small, not necessarily athletes, but people who are pretty well, who are having more minor procedures or intermediate procedures, who really don't need a very extensive input from pre-assessment. They certainly don't need to come and sit in our pre-assessment units for days on end, or at least half a day to have a load of tests, because actually there's not really much the input that they need. And then as you go down this slide, you can see that there are patients with more controlled comorbidities who perhaps need a little bit more input, perhaps a few blood tests or an ECG or whatever, but really not loads of input. And then the ones at the bottom are the ones where the resource probably needs to be spent. So the point is that if you screen patients early and triage them into these categories, you can better address their needs. But also, not only can you address their needs, you can free up some resource from these lower risk patients and allocate it more effectively to the patients who need the resource. Also, you identify a pool of lower risk patients who perhaps can be used to backfill slots. And I'm going to come to this when I look at the cancellation audit in a minute. So these low-risk patients need minimal input from pre-assessment. They may be able to fill last-minute cancellation slots, and they certainly don't want to waste lots of time being pre-assessed. And I know Jagdeep's going to talk about what we need to do with the high-risk patients later. So it's all very well saying that we need to be doing this early screening and triaging patients into different pathways for their pre-assessment journey. But I thought I'd also signpost you to some guidance that's out there to support the delivery of this. And GERFT produced some really excellent preoperative assessment guidelines, which in 2023, which show you how you need to do this. And I'll just show on some slides now a couple of sections from this guideline which support with the early screening and optimisation. So this page gives a bit of guidance about the kinds of things that need to be identified in this process and optimised. So there are some lifestyle things, there are some medical things, and there are some interventions that they suggest. And then this slide, I think you'll agree, looks rather like the one that I showed earlier, this one. And I was very reassured when GERFT produced this, me having produced that other slide years and years before, because it looks rather the same, although it's presented in a rather more fancy Visio kind of way. And this really is is exactly the same as that idea of triaging patients into 3 categories. So screening them, triaging them, and then giving them different levels of pre-assessment. So moving on to 2025, at the beginning of this year, NHS England produced the elective reform plan, and you'll see there that point 2 says that we need to establish a maximum number of short notice cancellations, and that we need to review the current level of cancellations. And it also talks about, number 1, talks about only giving a date for surgery once they've had their pre-assessment. So I'm drawing your attention to the first 2 points because I think it's really important to think about early screening when we're thinking about addressing these points. So because postponements in pre-assessment and cancellations on the day of surgery happen because the beginning of the pathway, the early screening and triage and optimisation hasn't really happened properly. So I thought it would be helpful just to, and I think Ramai is going to speak a little bit about this as well, but just to outline what was found in this national audit that was took place in a week. So data was were collected in during the course of a week in November in 2024, and the results have been published at the beginning of this year. So we've seen nationally that postponement in pre-assessment, so that's when a patient comes to pre-assessment and they need something doing, which means that either their TCI date can't go ahead or their perioperative pathway is going to be delayed by at least 2 weeks. We found that happens about 8.7% of the time to patients who come through pre-assessment. And the top 3 reasons for this were, well, the top one was further preoperative investigations. Next one was further optimisation, and the next one was uncontrolled diabetes. So if we could identify that some of these things right at the beginning of the pathway, hopefully at the point they come for their pre-assessment, some of that may have already been done. And then you'll see that 37% of postponements when patients had already been given a TCI date. And then when we looked at cancellations, so these were patients who had a TCI date for surgery, and then they got cancelled within 24 hours of that. And it's nearly 10% of patients this happens to. So that's a huge number of patients who've, made plans, who are expecting to have surgery, who then within 24 hours of their operation date actually don't have an operation. So this is obviously a disaster for each of these individuals. And if you look at the reasons for this, it's broadly in 2 categories. The first one, as shown here, are reasons that are sort of related to booking and scheduling, particularly acute medical conditions, lists overrunning, patients not coming and not attending on the day of surgery, clinical staff not being unavailable, and emergency admissions, meaning that elective cases don't happen due to those emergencies. And you can imagine that if we've done some early screening and identified a pool of patients who could be available to backfill some of those slots if they're identified a little bit earlier, perhaps a bit earlier than 24 hours before, then perhaps that will fill those slots. I'm going to skip through that slide. And then the other broad group of reasons for cancellations within 24 hours were for reasons related to pre-assessment, and those include problems with pre-assessment, procedures no longer being necessary or wanted, and pre-existing medical conditions that perhaps could have been identified. So you can see that if we improve our processes right at the beginning of the pathway and do this early screening, identify problems, optimise early, we may be able to avoid some of these problems. And you'll see how early screening is the top recommendation that's come out of the PACE audit to try to improve the problems that crop up further along the pathway, so that get identified later, so postponement, that result in postponements, and then subsequently can even result in cancellations, which of course are the things that we really, really want to avoid. And then you can see the rest of the list there. So you may say to me, well, how much early screening is going on around the country? And I think these data are quite helpful to see. The answer is it's a bit variable by specialty, but the best case scenario is about a third of patients are being early screened, and this is as yet unformally published data from the census that we did over the end of last year and beginning of this year of preoperative assessment services. And why are people having problems implementing early screening? Well, you'll see that the top reason there is digital capability, and I know that Rama is going to talk in a lot of detail about how that can be addressed in her talk in a minute. So that I think is really important, and of course it takes time to develop a digital system so we can that has the capabilities to do early screening. So that's important. Financial reasons are important, and workforce is obviously another big reason why people have struggled to implement early screening. So I hope that that's given a good overview of what the overall objectives of the NHS perioperative care team are, and how we're trying to go about them, and how early screening fits into all of that to try and address problems right at the beginning of the perioperative pathway, to smooth the way for patients through the rest of their pathway. And I hope it also gives a good lead into the next talk about digitalisation, which will hopefully give you a steer on how you might go about actually delivering some early screening. Thank you.
Oh, Joanna, you've not let us down. I gave you the big build up and you've delivered. Thank you very much. Would anybody, we've got about 5 minutes of Q&A set aside. Would anybody like to offer an opinion or ask a question of Joanna while we have her here? I'll just let people contemplate that for a moment or two. You see, Joe, that's either because it was so comprehensively outstanding that people are just standing now in front of their monitors, open-mouthed in astonishment at what they've heard, or, it's lunchtime, they just can't think of a question. I suspect it's the former. Let's hope so anyway.
Let's hope so. And I think as someone who's been a pre-assessment lead in a local district general hospital, I completely understand that actually this results to implement this requires a lot of changing of pathways, existing pathways which are very established, and changing the way staff work, some additional resource in some cases, and of course all of that is very challenging, and particularly at the moment while we're all under such financial pressures as well. So I hope that that's given an overview as to the importance of this, and why it improves the perioperative pathways, but also how it can fit in with improving efficiencies as well. And that it's just getting over those first hurdles, which I think Ramai's talk will give a bit more insight into. Thank you, everyone, for listening.
Thank you, Joe. We really appreciate your time. And really appreciate the content, actually, that you've provided. And if you're wondering, we will, if it's okay with you, Joe, we'll make these slides available to audience members subsequent to today. My able operations manager, Jade Maloney, will send those out to people should you like them. Okay, well, Joe, let's move along in that case. Thank you so much for coming along and giving us such a great start today. I'm delighted to now welcome one of our Guy's and St Thomas's real kind of royalty here in terms of what they're capable of doing, a kind of a showcase for all that Guy's and St Thomas's do on behalf of both the Institute and for their staff and patients. This is Dr. Ramai Santharipala. I'm not going to read Ramai's post-nominal letters because they are so extensive that we'll be here till next Thursday. What I am going to be able to tell you is that Dr. Ramai is going to talk about digital pathway redesign to enable early screening, and this is a case study from within Guy's and St Thomas's and all that Ramai is responsible for. So Ramai, if I may hand straight over to you, because people don't want to hear my ramblings,
I'm going to let you go straight into it. Thank you very much.
So thanks very much. I think that was a fantastic, it was a very generous introduction, and we also have Jagdeep as well, who's supporting this project as well, on behalf of Guy's and St Thomas's. So I just wanted to segue from Joe, who's really given us a brilliant national picture, and to essentially a case study of what we've done at Guy's and St Thomas's within this sphere. So Joe's already kind of touched upon this, but just, looking from the outside in, we have these late identification of quite complex patients, and Jagdeep's going to be speaking about the kind of higher end of complexity there. But we also have to remember that at the heart of this, there is a patient, and, there's a patient that's preparing for surgery, has taken time off, perhaps had carers do similar. And it's really disappointing and a poor patient experience to kind of go through some of the functional obstacles that we sometimes have actually within our preoperative assessment pathways at the moment. And we all know that we've got this elective backlog that changes in numbers, somewhere over the 7 million proportions. And this comes at a time when, if you speak to the frontline workforce, there's a lot of morale and recruitment and retention issues. And I'm coming from this from a kind of Royal College of Anaesthetists Council perspective as well. So there's a real kind of complexities of problems at the moment. And Joe alluded to this, that there's a number of guidance that really impose the value of early screening. So screening patients, ideally digitally led, very early in the pathway. And I'm not going to go through that to any extent because I think Joe's articulated that brilliantly. But what I will add also is that there's a couple of other factors to consider. So obviously there was a Darcy report which spoke about digitalization and how, within the NHS, it's still an aspiration. I mean, sometimes it takes me 20 minutes just to log onto a computer. So, we really need to enable those digital processes. And then in and out is this vogue is the concept of elective hubs. So, specific non-acute sites, so non-acute site hubs where we can actually plan surgeries that are appropriate. So there was just to point to a couple of pieces of national guidance, which is particularly important. So the Centre of Perioperative Care, of which I'm a board member and Jagdeep's the deputy director, released some guidance very recently, actually, around this concept of pre-screening. So really tying in that early concept, but also just remembering that actually even before a patient has seen a surgeon, starting that process. So actually at that first surgical outpatient, we already have a holistic view of who that patient is in front of us. And why is that important? Well, actually, it means that we can streamline those patients who are fit and well. So Joe kind of mentioned the green pathway, and then start to optimize those patients that perhaps need a little bit more input. And this was echoed in the PACE audit, and Joe's gone through this in a huge amount of detail, but just really to emphasize that starting this process early means that actually we can streamline and we can smooth out the patient experience and the patient pathway. And I think from a patient perspective, that's obviously fantastic. But as a clinician who's actually sitting in a clinic myself today, it just mitigates some of the problems that I'm raising and seeing on a daily basis. So, for example, patients who are having surgery in the imminent future and having to essentially work out a plan for them in quite an expedited way. I'll pass on this because Joe's already mentioned, the reasons that surgery is postponed, but effectively it's because of poor planning. So just to reiterate, for those who perhaps are outside the perioperative sphere, this is our surgical pathway as it currently sits. So a patient may go to a general practitioner with a symptom such as knee pain, and then they wait for a surgical outpatient appointment, and they go through essentially a referral process and then a vetting process by the surgeons as to whether that outpatient is appropriate or not. And in the current system, more than likely, a patient is consented for surgery. So, a discussion that surgery is the most viable option happens. And it's that kind of discussion and then the kind of actual setting, the data surgery that triggers the pre-assessment process. So the setting of the TCI. And Joe mentioned how actually there's a national direction that actually we shouldn't be doing that. And one of the reasons is because it minimizes the amount of time that we have to prepare patients ahead of surgery. So not only kind of, receiving that full holistic view of who that patient is, but actually, implementing changes such as smoking cessation, weight reduction, really simple lifestyle interventions that might actually help the patient post-operatively, so after surgery. So really what we were trying to move towards at Guy's and St Thomas's in this pilot is the concept of early screening. So starting to screen patients, ideally before their first surgical outpatients, although, at the very latest, at the point of the first surgical outpatients. And what does that do? Well, it completely transforms the experience for the patient and also for clinicians and operational teams involved. So not only does a patient, get that screening questionnaire early, so they know that they're in the system, they're being considered, it means that by the time we get to that first surgical outpatients, we already have an overview of, whether that patient's able to be expedited, for example, or what kind of investigations that may be needed. And what it does is it maximizes what's known as that optimization window, so the ability to support a patient and make sure that they're adequately prepared and actually, optimally prepared ahead of surgery. And we know this has impact on outcomes after surgery, as well as improving the patient experience. So what did we do? So we've developed the early screening tool, and at the time of this, so this was when My Planned Care, which came out in March 2023, came out. We started to develop this tool. So we actually looked at various digital supplies and decided that there was nothing to maneuver. And at that point, although it's a very rapidly evolving field, at that point, the concept of screening was really early on. We looked at 26 preoperative questionnaires, and they were quite detailed questionnaires. So again, that concept of screening really hadn't come through. We liaised with clinical and operational teams, and we also had significant amount of patient co-design. So patients have really driven this project, which is quite unique, I think, to this project. And what we delineated was what's known as discriminatory questions. So which questions do we actually need? So what's the kind of, not so much the minimum, but what's the optimal number of questions that patients, can fill out easily, that we can reduce that clinical risk and identify those patients who can be fast-tracked. And we developed a functional long list and then a short list and then technical requirements, because it's obviously a digital solution. We produced a prototype, tested that, and then went through a feasibility pilot, which I'll go through in a moment, and then iterated to the current impact evaluation that we're doing at the moment. So for our feasibility pilot, so we developed the tool and we're testing it in 4 surgical specialties, so 244 patients in total. And like I said, there was a lot of development into the kind of questions that we needed, and patients really drove that. And it was really brilliant because actually, word for word, we went through every single question. And I think that's borne out in some of the results. And I think, really have to thank our patient groups for that. We had high digital accessibility, so only about 7 of those 244 patients needed support from our clinical nurse specialist who supports this pilot work. We had a rapid response rate, so this was 69% of patients were responding within 24 hours of receipt. And we found that 44% of patients in this particular pilot were able to be fast-tracked. I have to caveat that we chose kind of surgical pathways that were more delineated towards patients that can have same-day surgery, so surgery in a day case or an elective hub. But still, it surprised us to have these figures. I have to say the one aspect is that we did this with a third-party supplier at the moment, very proficient in this, and we obviously have had to rebuild it into Epic. So South East London is now on an Epic system, and we very much follow that principle that obviously, we try and build within our own system first ahead of using third-party suppliers. But still, this was very encouraging for us. And we had an independent analysis. So I have to say all of this analysis was done by the Health Innovation Network, so of South London, so independent. And that was, an aspiration of mine personally. I really wanted to make sure we weren't marking our own homework. But, there was real aspiration that regardless of age, ethnicity or gender, that patients were able to fill out this digital tool. And, a lot of questions always come up about our kind of natural biases towards, digital implementation. And I hope these figures give you some reassurance. So we had a roughly equal split from a gender perspective. But actually, if you look across the ages, you'll see actually that, all these age groups actually perform well in completing the questionnaire. So I think, you know, that goes against some of the natural biases that people may have with respect to digital tools. And it just goes to show actually that you have to evaluate, and I would say independently evaluate, because until you do, you just don't know. And that's particularly important, I think, you know, from a digital inclusion perspective. So this is our index of multiple deprivations that we have across South East London. So South East London has got one of the highest index of multiple deprivations within the UK. And again, we just wanted to make sure that the patients involved in the pilot were very reflective of the population that we serve. And you can see from this that they were. So we went into a phase which is Guy's and St Thomas's funded, and this was actually to, you know, start to gently disrupt the pathway. So essentially implement early screening into our pathways and have it as the kind of the mode of which patients are prepared ahead of surgery. So we iterated the early screening tool, and this was based on the HIN evaluation. And it was really interesting because there was a few questions about high blood pressure, obesity, airway, that just needed some tweaks for patients to understand better so that we can implement the tool better. We developed an evaluation framework, so the HIN have been our continuous evaluation partners, and they're evaluating the current phase of the work as well. We worked with clinical pathways and stakeholders to really start, you know, gently, like I said, disrupting those pathways. So starting to get the tool in very early. Our surgical teams have been fantastic. We developed our patient advisory group. So we had kind of a number of patients come from various groups and actually just formally brought them together. And again, you know, they've really driven this project, and it's been fantastic working with them. And it's really interesting, some of the nuances that you learn from listening to them. We rebuilt this tool within MyChart. So like I said, we went into an Epic first solution. We developed standard operating procedures, worked with the workflows, and then went live in December. And I have to say, you know, we went live at the time that on the background of, you know, South East London undergoing one of its biggest digital transformation projects. So, you know, again, really have to thank the team for their hard work around that, because it was not easy. We went live in general surgery with two specific pathways. We started with a very phased go live, and I think that also iterates. Actually, there's a lot of anxiety around digital implementation. I think we just wanted to give both patients and clinicians and operational teams an understanding that you know, these pathways are going to be tested and go well. So we did a phased go live with one clinician, and we've onboarded further clinicians since, and we're already starting to see patient benefit. And like I said, formal HIN evaluation will be available later this year, but we're evaluating it in the background just with the data that we can draw down at the moment. And what we're finding, and this kind of speaks to Joe's classifications, is that around 17% of our patients at the moment are deemed what we know as low complexity. And then when we match them to, you know, do they fit the criteria to have surgery on the day, we've got, you know, that flow of pathway, and we've put them onto what's known as a gold pathway, which is very light touch. So they have a swab. They essentially have a swab, and then they can be set for surgery. And actually, that's a really interesting expedited pathway. And we've had patients go from receiving the questionnaire to having their surgery within 14 days on that pathway, which is fantastic. And then the other patients which fall into the cohort of medium-high complexity, we've split them into those patients that, again, meet the criteria for same-day surgery and then can go onto a green pathway. In essence, you know, have a very light touch pre-assessment, so not the full process as we know it now, which is fairly complex and lengthy, obviously appropriate for certain patients. So again, they can be fast-tracked of sort with the light touch pre-assessment. And then the remaining patients, which Jagdeep will speak to in detail, are those patients that do need the workup and do need the full kind of pre-assessment processes. And obviously, you know, that's where POPs have excellent expertise as well. So I'll leave that to Jagdeep to speak further on. And what are we seeing so far? So some really kind of early tangible benefits. And this is, for me, I think this is the most interesting, although it's really fantastic to be able to fast track patients. Actually, it's the potential for optimization that personally for me has been really valuable to see. So far, we've referred patients onto smoking cessations, of which, a small number have taken up that opportunity. Again, something perhaps that we can tweak in the process, in the communication, to increase that uptake. We've had patients with abnormal blood tests, and they've gone on to have the relevant investigations through their general practitioner. So we referred them signposted them to their general practitioner to have those relevant blood tests. And then onwards, their general practitioner has been able to make diagnosis. So, and further investigation, so an OGD or alcoholic liver disease. We've had patients that, either have had undiagnosed problems such as hypertension, or have needed reviews for those chronic health problems. And then we've had patients similarly kind of with heart failure, which perhaps need optimization. And the real kind of win is that you start that process early. And like I said, I'm sat in clinic today, and, the benefits of this to any clinician is obvious. We're doing a HIN evaluation at the moment, and that's going to involve patient experience and patient outcomes. So we're going to do some patient interviews as well, which will be, I think, always delightful to see. I think, it's brilliant just hearing what an impact these processes have. And we've heard informally, particularly from patients who've been on that fast track pathway, how expedient it's been for them. We're looking at things like on-the-day cancellations. We're looking at how well our theatres are utilised, and the kind of cost savings from that perspective. We're doing a health economic analysis, and that's going to be threefold, looking at the current impact evaluation and, what's the health economic advantage of that. Looking at kind of the projections going forward. So how would we business case this? How would we build the model so that actually it's equitable at the very least? Or from a health economic perspective, cost neutral. And then obviously what's really important is digital inclusion. So we're looking at factors and barriers to that. And what's been really interesting, actually, just looking at the early data. So we've got a digital inclusion rate of just over 10%. But when we break down that data, a lot is to do with the functionalities that we have within our EPIC system. So, for example, at our trust, we changed the way that we message patients. So we actually said, it goes to their preferred contact, which sometimes could be email. So when our nurse specialist was phoning patients to see if they've, received the questionnaire, they actually said they hadn't, and it's because it's gone to an email address rather than to a simple text message. So just making that flip has changed us reverted us to lower digital exclusion rates. So again, that's been quite interesting because it's against the natural bias, particularly for our population, that digital exclusion rates would be high because of actually functional kind of equity reasons. It's not been an easy ride at any point, really, but actually it's been fantastic just to learn from the whole process, and actually, not having a clear innovation pathway is something that's become quite obvious to us, and that's something that we're building on, and that's common to the NHS. Aligning kind of to the trust strategic alignment and certain priorities, and looking at the bigger picture. I think at the NHS, particularly in the current context, and there's uncertainties obviously at a national and policy level, it's trying to align with them. The kind of the changing landscape has been an interesting exercise, let's say, and I think again you can learn from that. Finding the right team members. I have a fantastic team behind this, and as some of you will know, so a brilliant program manager. Our nurse specialist, Lepalele, is very unique, and actually taking time to find those right team members is again a process, but absolutely formidable going forward. As a clinician, it was really interesting working with third parties. It's not something I personally had any experience of prior, and actually it's quite interesting because it's just two-way learning through the whole process, and actually just maintaining momentum. So again, lots of complexities. We've had kind of industrial action, obviously, thankfully that's in the past now. We've had lots of kind of complexities that have added to this, but actually even more so to me, it makes complete sense to have what Joe described, those bank of patients that can have their surgery that are cleared. So just to say big thanks to kind of Guy's and St Thomas's charity, obviously, for funding this work. My own directorate in cancer and surgery, who we sit under, those across South East London who have supported this work as well. Health Innovation Network, who continue to be our evaluation partners. Apollo, who are kind of our EPIC partners and, helped us immensely with rebuilding the tool, and our Centre for Innovation, Technology and Improvement, who've really, provided some of the horsepower behind this as well. And just to kind of nicely segue into, we're in discussions with Jagdeep as Deputy Director, and also the other Deputy Director, Scarlett, with the Centre of Perioperative Care about, what are the next steps. We will have a HIN evaluation, like I said, later this year, and to really start to embed this practice and also start to spread this practice to those who, to relevant kind of trusts and networks that, want to adopt early screening.
Oh, goodness me, Jagdeep's in trouble here because we've had two absolutely star-studded presentations so far. Will Jagdeep make it a triple crown? Let's hope so. Ramai, that was magnificent. Thank you so much. I love the detail that you went into. I love that, as other people have commented, love the focus that you brought in on the patient. I love the fact you're doing follow-up interviews with the patients and so on, rather than just making this purely clinically centric. Would anybody like to ask Ramai a question or offer an opinion? Oh, Joe would like to ask a question, I think. Go ahead, Joe. Thank you.
I mean, everyone may have heard my voice too much already, but I've got a couple of questions. But I think, first of all, Ramo, it's just that's a brilliant example of how to implement early screening, and I think the patient involvement's fantastic. The involvement of external evaluation is really great, because not only is that useful to support your work, but it will help other trusts evidence what they want to do, which I think is going to be really helpful. I was interested that you look at some patients before they come to their outpatient appointment, so presumably some of them may not go ahead with surgery. Does that increase your workload quite a lot?
So that's a really interesting question, Joe, and Jagdeep and I have spoken at CPOC Exec about this as well when we presented to Jagdeep and colleagues there. It's really interesting. So we picked pathways that we know have a high conversion rate, so inguinal hernia, cholecystectomy. I have to say, and this is a learning for me, is that I obviously come from a perioperative lens, and I think all population health interventions are useful from a patient perspective. So picking something up in a patient who doesn't ultimately have surgery. And as most of you know, I am a shared decision-making enthusiast, and I think, it's as much of a impact to support a patient in the decision of not having surgery as it is to proceeding with surgery. I also think, that's also of benefit to patients. However, having said that, from an operational perspective, we've deliberately chosen pathways that have a high conversion rate. So, over kind of 80% conversion rate to surgery. Going forward, we probably will do it at the first surgical outpatient, just from a practicality perspective, because I don't think there's quite the operational buy-in yet for the wider population health argument. But that's not to say that it's not important, and I do think we should aspire for that in time. Because I think any new diagnosis, any new hypertension, diabetes, etc., that's picked up and can be followed up because they're screened with a potential intervention, whether that intervention goes ahead or not, I think ultimately in time, I would hope that we'd have a healthcare system that actually wants to screen patients because they want preventative care.
Thank you. That's really helpful. And just sort of linking into that, did you involve primary care in the setting up of your screening? Because presumably when all these things are being picked up, a lot of them are going to be sent, a lot of these diagnoses that you mentioned on the list of things that you found are going to be sent back to primary care to manage.
So yes, we did, and our nurse specialists signposts to primary care at the moment as well. And you know what is really interesting, and this is a sneak peek, because obviously they're here doing the evaluation concurrently to our impact evaluation. So our nurse specialist who sits in secondary care instigates some of the, optimization that needs within secondary care. So might order an echo, for example, or might order, iron studies because of a pickup of anemia. And what's really interesting, and we're looking at the kind of primary care versus secondary care interventions, and actually, understandably, because our primary care colleagues are, kind of somewhat overwhelmed at the moment, it's really interesting that actually the primary care pathways at the moment, perhaps don't support early screening to the extent that we'd want them to. And that's no disrespect to our GP colleagues, because I think they're amazing. And, one of my best friends is a GP's, but I just don't think we're set up from an operational perspective from that aspect. So it's really interesting. So I do think the early screening model sits in secondary care. And I think we have to find a way to model what that early screening nurse, if that's the role that evolves, that certainly from our modelling looks like the role that's evolving, can do within the remit within secondary care.
Yeah, thank you.
All right, let's. We're going to have to end it there. But Ramai, thank you so much. Box office, you've got the job. Congratulations.
I think you've got the star next, so I will go. Well,
we shall see. She's under a bit of pressure now. Under a bit of pressure, Desi. What can we say? I hope you're feeling it. I think, thrive on this adrenaline that is now coursing through your veins. Rise now, and you'll be grand, I'm sure. Look, we are so lucky. This is the most extraordinary kind of focus on perioperative care and optimisation of improving surgical waitlist. So, Jagdeep, come and do your best now. And just to remind everybody on the call, Jagdeep, it's Professor Jagdeep Desi. She is consultant geriatrician, a stalwart of Guy St Thomas's NHS Foundation Trust, big fan of the Institute of Health and Social Care Management, and most importantly of all, currently president of the British Geriatric Society. So Jagdeep, please wrap this up for us, top and tail it as you would, and looking forward to hearing you talking about the identification and optimization of the complex surgical patient. So over to you, if I may.
Yes, I'm going to talk about the complex surgical patient. So I suppose we could think about Doreen, couldn't we, if we really do want to have a patient-centred focus. So a 78-year-old living alone, little support, difficult history and label in the notes, a little bit of osteoarthritis, diabetes, hypertension, and maybe goes along to her GP because she's short of breath. And these are the kinds of patients that we all see all the time, aren't they? Whether we're working in primary care, in community services, or in secondary care. But say, for example, Doreen ends up being identified as being anemic as a factor for her breathlessness, and then goes on to be discovered to have any kind of surgical pathology. To be honest, it could be elective or emergency. So what happens to people like Doreen in current pathways? Well, actually, as kind of Ramai's already referenced, probably quite a lot of these patients we don't actually see in secondary care, because out there in the community, they've actually declined intervention for a whole host of different reasons. It might be because we've not been communicating properly. It might be because they've not understood what we've tried to communicate because of sensory or cognitive impairment. It might be because she says, well, I'm 78 and I haven't got long left and I don't think I should be having anything done. Or maybe her sister had a stoma and she says, I never want to go there, don't want that, don't want to have any tests for this. Or maybe she does get through that bit and then she does come up and she does get seen by pre-op assessment, and there she's identified as having these 3 different things going on. And then the pre-op assessment nurse refers her to an anemia clinic, a diabetes service, and tries to get an echo for her shortness of breath. And so this lady who lives alone, who's got osteoarthritis, is socially isolated, tries to find her way around these different appointments in time, maybe for her 2-week wait cancer surgery. Or maybe actually that bit goes really well as well, and she comes in on the day. But then, as we've heard from Joe, we're still seeing 8 to 9% of our patients being postponed on the day of surgery, for a variety of different reasons. It may be that this particular lady didn't follow her instructions because she couldn't read them. Maybe it's because then she's identified as having this breathlessness that the anaesthetist is worried about on the day. And of course, similar things can happen in the emergency setting as well. But maybe actually all of that's done really well. And maybe she goes and kind of gets seen electively, goes on to a prehabilitation program. They look at smoking, alcohol, exercise, nutrition, counselling. She comes in, she has exemplary evidence-based ERAS program immediately pre-op, intra-op and post-op, goes to the ITU unit, and there has perfect physiological control for the first 48 hours, and then comes back to the ward. Now, we know that people who have got underlying pain, like this lady has from her osteoarthritis, end up needing higher doses of analgesics post-operatively. We know that people who have diabetes have slower gut transit. That, together with the opiates, means that she's not eating very well. So then we ring up the diabetes team. They come along and say, actually, we ought to put her onto an intravenous insulin infusion. That goes up. But she doesn't drink quite enough and we don't match her fluids and she starts to develop an acute kidney injury. So then we give her some fluids because we think she's a bit dry, and we ring the renal team and they say, well, of course she needs some fluids. The fluids dilute her anemia, and then the juniors ring up the haematologists and say, well, we think we ought to give her some blood. So that goes in. And then as that goes in, she's sitting there tied down to these different drips and tubes with a low albumin level to start with. And then she starts to get some leg swelling. So then they ring up the heart failure doctors and they say, well, we ought to offload her. Let's give her some diuretics. That drops her sodium. The sodium drops, but we don't notice that. But we should think that she's being a little bit apathetic, not engaging. It must be that she's depressed. So then we put in some antidepressants. And you can see how this cycle unfolds, where you're trying to get all the right specialists involved along the pathway. But actually, what we're doing is causing hospital-acquired complications with delirium, deconditioning, acute kidney injury, and functional decline, such that she goes home worse than she came in, and needing that social support that we all know is so difficult to access at the moment. So I suppose that brings us on to, well, who is a complex patient? Because in some ways, Doreen doesn't look that complex. But as RAMI's data shows, around about 50% of the patient population that they've been looking at does actually fall into this group. So this is a large volume group. We've always talked about high volume, low complexity, but actually we've got a pretty high volume of high complexity patients. And when we're talking about the kind of the patient at risk, then it's really these kinds of outcomes that we're thinking about. We're thinking about being at high risk of clinician reported, patient reported, process related outcomes. So you can see exactly what patient group is particularly at risk. And certainly the literature over the last 20, 25 years now has shown us that the independent risk factors for adverse post-operative outcome, from whoever's perspective we're looking at that, relate to poor physiological status. They relate to socioeconomic factors and behavioural issues. They relate to the presence of multimorbidity rather than single organ disease, and to geriatric syndromes like frailty and cognitive issues. And this is a numerical issue for us. That's why it's 50% of our waiting list now being actually particularly, high risk patients, because 1 in 4 of our population is aged over 65. And we know that the things that we do surgery for, whether that's degenerative disease, neoplastic or vascular, they all happen with increasing frequency as people get older. So this is a numerical issue for us. And all of that really adds up to telling us, we absolutely need a new approach. We need transformation of our pathways. We've got increasing numbers of people living with complexity, and they're the ones who are having surgery. That complexity is what results in risk. We know that the majority of this population are going to be older because of that profile, and we've got to adapt our services because this is having system level impact. It's having impact for primary care, community services, secondary care, but also for social services and the workplace and pensions and, everything really across the country. So what does this new model need to deliver? And as Rami's kind of shown, we've been really kind of focusing on making sure that we do have patients and the public at the centre of developing any of these new pathways of care. And that's certainly the approach that's been taken in the development of POPs type services, engaging with local populations to work out what people want from the whole pathway, which is invariably, they tell us, needs to be joined up, seamless, honest and transparent, with a single point of access, delivered by people who want to kind of have a holistic view on what's going on with the patient. But they also tell us about the things that actually matter to them after surgery. And interestingly enough, a lot of that does relate to these hospital-acquired complications, particularly the impact of post-operative cognitive issues like delirium, people saying that their dad was never the same after that hip replacement, or related to functional recovery, actually getting back to independence. Those are the things that patients tell us matter. But they also tell us that it really matters that we help to support in shared decision making, that we switch the narrative from what's the matter with patients to what matters to a patient. So it's not so much what are we doing for this particular condition that the patient might have, but what can we do that will help with symptoms or quality of life, what might help with longevity and being able to live longer, but also talking about the mode of death and what might happen if we don't do something and what's likely to then happen for the patient. But I think often when we talk about co-production, we focus very much on patients and the public, and that's kind of rightly so. But it's equally important that we understand co-production from a healthcare professional's point of view. And Jo kind of mentioned that about kind of primary care and how they've been engaging with the work that Ramai has been looking at. And certainly here again, when we've been looking at the complex surgical patient, we've explored what surgical trainees kind of understand about this, what anaesthetists and primary care practitioners understand. So then we can make sure that we're developing pathways that the healthcare profession is bought into, because otherwise you're again enforcing a particular pathway onto a population and then expecting them to get on with it, rather than understanding what they want to be able to deliver as well. So all of that work really kind of for the complex patient really sums up into telling us that we need to understand how to identify issues through screening, assess and diagnose these issues within this population, but focus on optimisation across medical, functional, social and psychological domains, so that we are looking at the patient as a whole and we are planning care throughout the perioperative pathway with hands-on involvement, all of which needs to be underpinned with shared decision making. So that's all kind of well and good, isn't it? Because that's all the kind of theory and what everyone tells us that they'd want to happen. But how do we actually make this happen? How do we operationalize this? And of course, that does absolutely have to start with systematic identification of these risk factors, of identifying the high risk population or the complex population. And again, here, this is where, you know, this data and approaches that both Jo and Ramai have referenced really come into their own, because we absolutely have to be using data from primary and community care effectively to be able to build up the picture of that population. We need to embed screening at the front door, wherever we describe that front door being, whether that's out there in the community, and certainly lots of work that we're doing from the British Geriatric Society, working with primary care at being able to describe the population locally for them. But also in the surgical setting, in the emergency setting, we have now been working with the Royal College of Emergency Medicine to embed triple assessment for all over 65s coming in at the front door. So everybody should have a NEWS score, but also a 4AT to assess for cognition and a CFS to assess for frailty. Because then we can start to triage people as early as possible, even through that emergency pathway. And then in the elective pathway, we've got the preoperative assessment screening tools that Jo has mentioned already. But within that, we do need to start to make sure that we're focusing in on things like polypharmacy, which we know are risk factors for people doing badly. And these are relatively simple tools that we can embed into preoperative assessment, as Ramai has shown. And of course, all of that is advocated through national guidance now. And an example being for the frailty side of things, we've got the CPOC BGS guidelines for frailty in the perioperative setting, both elective and emergency, with very clear kind of infographics and things that we can use to be able to embed these relatively straightforward models of care. So we can identify people, but then what do we do? And I think this is where we need to work with the whole of our workforce, whether that's again out in primary and community care, or whether that's in the first surgical consult or at preoperative assessment. And there are so many different resources available for this. The amazing kind of 1 minute, make every contact count approach that primary care practitioners use, for example, for smoking and alcohol and weight management. Lots of resources around frailty available from the Frailty Hub at the BGS, shared decision-making resources, and summing up and signposting to lots of these different resources through the CPOC website as well. But we need to encourage our staff to be using every one of those contacts to make them count for the patient. Because that's when it allows us to start care off on the right foot. Because if you've picked up that someone's got a 4AT that indicates that they may be at risk of cognitive issues, then you can start to talk to patients about the risk of delirium and use resources from the delirium hub at the BGS to have those conversations. And you can start to use your local guidance to ensure that we're getting everybody recognizing that this patient is at risk of delirium, and what can we do to avoid that happening through the pathway. So lots of resources there that we can be using again. But that's also the point at which we have to acknowledge when additional expertise is required. Because if you've again described that population really well at that first encounter, then you can identify who needs to be seen in a high-risk anaesthetic clinic, or who may actually benefit from geriatric medicine within that setting. And this is kind of where the CGA-based model of care comes into its own for patients, particularly living with multimorbidity, frailty or cognitive impairment, functional issues, or whether are difficult decision-making issues where we're not quite sure whether surgery is or isn't the right thing. And this is the schematic for the POPS model, which was started at Guy's and St Thomas's, but has now been established at kind of 40 UK hospitals, 10 over in Australia, and kind of a number across Europe as well. And again, this is all to be used. So, these aren't, these are things that are freely available for everyone to access and start to use, including, for example, our referral posters that we have up in our surgical consult clinics. And that is where it allows us to deliver care in a one-stop service, which is what our patients have told us that they want. So people like Doreen not wanting to go to a diabetes anemia clinic and then go for an echo and everything before she comes in, but instead go to a CGA-based POPS clinic, where what we're finding is that we're making 2/3 of our patients are having a new diagnosis made in clinic, lots of things unrecognised for lots of different reasons. 3/4 having their medicines changed, a lot of therapy and lifestyle intervention. Interestingly enough, only 1 in 20 being referred on to another organ specialty for any advice. So this can be delivered in a one-stop service. You do not have to send these patients to multiple clinics. And of course, that's really important for our waiting lists, when we know that 1/3 of all 65-year-olds across the country are on at least one waiting list, and many of them are on far more than that one. The other thing that happens through this service is that we find that 1 in 7 patients choose not to go ahead with the operation that was originally proposed. That's because we've been able to describe the wider benefits and risks, the alternatives, and what will happen if we do nothing with those patients. And actually, that increases up to 1 in 4 in the abdominal aortic aneurysm population. And again, I can go into the detail with you for that. But what's probably one of the most interesting things about this is that if you follow those patients up at a year, around about 40% of them have died at a year. But the majority have died of non-aneurysm related causes. These patients were in the last year of their lives, and yet we were planning to put in this expensive aortic graft, which isn't good for the healthcare economy, but most importantly, it's not good for a patient in their last year of life to be spending their time going back and forth to hospital. So lots of interesting stuff that's come out of that paper. And we know that this can be implemented across the country because we've now established this at other POP centres, seeing almost exactly the same results between 1 in 7 up to 1 in 4 patients choosing not to go ahead with an operation after a full shared decision-making process. So if we go back to Doreen, kind of what happens for somebody like her? Well, of course, it depends on whether it's emergency or elective surgery, but there's lots that happens. But it does require quite a lot of putting together of different guidelines, using the evidence base that we have, extrapolating that to that individual patient. So it's interesting medicine, but it does require a specific skill set to be able to do all of this in a one-stop clinic. The other question that we often get asked is, well, isn't this the same as prehab? And actually, that's really interesting because what we're seeing from the prehab studies is that we're not seeing the same benefits for older people as we're seeing for younger people. And that's probably because prehab traditionally doesn't include the medical bit. And there's so much medicine, kind of those new diagnoses, medical management changes that are happening in a CGA-based approach that doesn't happen in a prehab program. But you can see then, if you do all of that stuff well up front, then it allows the post-operative period to be delivered in a much more planned approach where you're able to identify what the risks are, manage them better, co-management on the ward with proactive identification of complications and management of them by a team who knows the patient. And we've seen how that approach really does improve outcomes. So we know that 40% of delirium is preventable. We know that deconditioning is preventable. We know that we can reduce length of stay by 40% by these types of interventions. The question often then arises, yes, but that's really expensive. So how do we actually do that? And these are just some of the metrics that some of the hospitals that we've worked with have used to illustrate how refashioning the money actually delivers cost savings. And we've done some academic work that shows that we save around about £1,500 per patient by using this approach. So it's actually cheaper than our current ways in which we deliver this type of care. So these are just some of the metrics there. The other question is always the workforce. Well, where do we get the workforce to deliver this? And again, this is about refashioning our workforce rather than asking for more, because we all know that that's not going to happen anytime soon. So how do we upskill people who we currently employ to deliver patient-centered care for the majority of patients sitting in hospital beds? 66% of our beds are occupied by people aged over 65. Everybody needs to know the basics of geriatric medicine. And again, these are some of the programs that we've established to support education and training. So what about implementation at scale? That's another session of another whole, probably lunchtime session, John, where it's talking in more detail about funding workforce, the real importance of standards, processes, but also cultures, the use of quality improvement and implementation science to be able to embed these types of services. But at the moment, we are running a big NIHR study across 18 hospitals where we're looking to see, can we implement these types of services in late adopter sites? And do they still deliver clinical and cost effectiveness in those very different types of hospitals, district general hospitals across the 4 nations? So more to come from that. So what should everybody do today when they go back home? Well, probably it's Friday, isn't it? So probably have a cup of tea or something stronger and have a nice weekend if you're not working. But otherwise, we should all be recognising we're all going to be looking after older people living with complexity. We absolutely have to embed appropriate screening tools into preoperative assessment, which are easy to deliver, but identify the high-risk population early. We should be using our data to inform our local services, whether that's NELA, NHFD, or that from GERFT. Lots of education and training resources like those on the BGS website. We've got to be multi-specialty in our approach rather than being single specialty focused. Patients are not presenting with single comorbid conditions anymore, and there are lots of resources available to support everybody in doing that.
Goodness me, Jagdeep. I mean, I think you've nailed it. Congratulations. I think this is just box office. And not only, I mean, I've been watching the slides as you've been talking, but the thing I really marvel at is the sheer number of clinical studies that you personally have contributed to having published. I've got no idea where you find the time and energy to do all of that, but it is extraordinary. So thank you. You know, if any of us really wanted an expert analysis of just what's going on in terms of geriatric frail older people and some of the considerations, I think you've absolutely nailed that. So thank you. And in that I sing in a male voice choir, and as with many male voice choirs, they tend to be slightly older people. I might even take some of these slides and show them, to be quite honest. Or better still, bring them all to guys at St Thomas's and we'll come and sing for you. And you can ask them in person.
Yeah, no, that'd be absolutely amazing. And John, I think, the importance about the research is, it is so key. But I think just to reassure others on the call, I've been employed in a full-time NHS clinical contract throughout kind of my consultant career. So, but the work's been done by clinicians. And pretty much every one of these papers has had one of our junior doctors who's, again, in a full-time clinical post, really committed to, delivering patient-centered research that they feel makes a tangible difference on the shop floor. So, it's all kudos to the wider team, our resident doctors, and certainly our clinical nurse specialists within our team as well. So that's kind of reflects back on what Ramai was saying. It's the team, isn't it, that is absolutely key.
Well, and many of the people on the call today will not know that Jagdeep's actually on annual leave at the moment. So she's dialing in, she's giving up some of her holiday to come and talk to us and share her expertise. We've got about 2 minutes for questions. If there are any questions, to be quite honest with you, it's almost superfluous because it was all so comprehensive from 3 absolute titans of surgical waitlist management. And I can't believe anybody would have a question, but if you do, act now. You see, I was right. Everybody's just dumbfounded by the excellence of what they've been presented with. Goodness me. Well, I have to say, as kind of hour and 12-minute sessions go, that's just flown past. So that's entirely thanks to the excellence of our presenters today, Joanna, Ramai and Jagdeep. And my goodness me, we've been an absolute treat for us all to listen to all of that. So thank you so much. Jade, the fabulous, the one and only Jade Maloney, our operations manager at the Institute of Health and Social Care Management, has put links for all of the different slide presentations in the chat. So if you would like to download any of those, please do that now so that it's not the kind of screen hasn't suddenly vanished and you're thinking, oh blast, I wish I'd downloaded it. But all I'm going to say is to all 3 of you, thank you so much for giving up your lunchtime and coming to chat to us. I know this will have hundreds, if not thousands, of downloads as we make it available through recording now. So thank you very much. And please keep up the good work that you're all doing. It is noticed, it is valued, and we do appreciate it. And that's for all of your colleagues as well. So thank you very much. Let's wish them all bye-bye. Have a super weekend, everybody. If you are working, thank you very much on behalf of the rest of us citizens. And we'll leave it at that for today. Thank you very much for tuning in. Bye-bye.